So the topic that I'm going to speak today is about predicting developing sepsis, CBC and more. So many times we've seen, patients coming to clinicians OPDs and there is some bacterial infection visible from the CBC, and usually the doctor writes an antibiotic to the patient and says that, take it for 5-7 days and then we'll review the CBCs. And sometimes within 48 hours, that patient from bacteremia goes into sepsis and in emergency has to be brought into the hospital because the sepsis was not able to be detected early enough. So the whole concept of this study is to see whether we could ascertain certain parameters or certain signs from the CBC which could aid the clinician towards an impending or already development of an early sepsis. Because procalcitonin, which is the marker for sepsis, is usually not done as an acute phase reactant in this country. So the background is that, as we all know, bacteremia is defined as the presence of viable bacteria in the bloodstream. And once the bacteremia sets in, it can, in an immunocompromised patient, infect the bloodstream, progress into SIRS, move to sepsis, sepsis shock, and even, multi-organ failure. We all know the progression. And the mortality from sepsis can be anywhere between 25 to 30%. And once septic shock sets in, the mortality is 40 to 70%. So the key to managing sepsis is prompt or early diagnosis and appropriate treatment to bring down the mortality rate. Of course, microbiological techniques such as rapid blood cultures have helped a lot in early detection of infection and also to identify the antibiotic which will, be susceptible or resistant. And also the development of procalcitonin, which is used both to diagnose as well as to monitor and prognose sepsis, has been well established. So currently procalcitonin is an FDA approved test for diagnosis of sepsis. However, this test has limitations both in terms of high costs as well as the turnaround time. So usually it needs to go to a chemiluminescent analyzer or a alpha technology, and it would take a couple of hours to do. And because of its high cost, it is not routinely asked along with the CBC. So basically, what we need to do is we need to diagnose sepsis early enough to prevent its mortality and use rapid blood cultures and procalcitonin to augment this thing. And also we need to measure bilirubin and creatinine to determine multi-organ failure. And the marker that is currently used as an acute phase reactant in clinical practice is CRP, which is a good marker for acute phase reactant, but unfortunately is not sensitive enough in sepsis to differentiate bacteremia from sepsis. So the objective of the current study is to evaluate certain novel hematological parameters like NEUT-Y, mono-Z, neutrophil lymphocyte ratio or NLR, and immature granulocytes, and see whether each one of them or maybe more than one of them can differentiate bacteremia from sepsis. So before I go further, let me also tell you that what is NEUT-Y and mono-Z, because these may be some new parameters for some of you. Another objective was to assess whether these parameters can be used to predict severity of sepsis, just like procalcitonin. So a rising procalcitonin means that the sepsis is becoming more severe. Likewise, a falling procalcitonin means that the antibiotic is working, and maybe at a particular value of procalcitonin along with other clinical signs, you can wean the patient off antibiotics. So can any of these parameters play that role in terms of quantitative, prediction of severity of sepsis? So basically, before understanding NEUT-Y and mono-Z, you need to understand what is a fluorescent flow cytometry. So a laser light flows through an aperture, and there is a forward scatter which is detected by cell volume, and basically this forward scatter is nothing but the Z axis. So maybe NEUT-Z, mono-Z, lympho-Z, all Z are showing the forward scatter of that particular cell type, and is depicting primarily how big or small is the average neutrophil or the average lymphocyte monocyte in that particular sample. Similarly, the x-axis is determined by the side scatter light or the internal structure, or the number of organelles or the granularity of the particular cell line, and the Y depicts the site fluorescence or the RNA or DNA information. So the higher the fluorescence, the higher is the RNA DNA content in that cell line. So when I'm saying mute Y, I'm particularly looking at the site fluorescence in the neutrophil, which means that the higher the mute Y, the more is the fluorescence in the neutrophil, and that means the higher is the RNA and DNA content. Indirectly, it is also an indicator of the immaturity of that neutrophil, because the more immature the neutrophil, the higher will be the RNA and DNA content. Likewise, when I'm looking at mono Z, I'm looking at how big is the monocyte. So the larger the monocyte, the more will be the mono Z. So with this basic understanding, the materials that we used for our study was, for procalcitonin, we used the chemiluminescence system from Mindray 960i. For the CBC parameters, we use Mindray BC 6800 plus, which has the capability to differentiate Nutex, Nut-Y, Nut-Z. Likewise for all the cell lines. And for blood culture, we use the rapid blood culture system from bioMérieux Bactlut 3D. So what we used here was a simple 4-step methodology. Before doing the study, we first had to establish biological reference interval for all these 4 parameters: Nut-Y, mono-Z, immature granulocytes meaning myelocytes and metamyelocytes but not band forms, and to determine the neutrophil lymphocyte ratio in healthy patients. So after using appropriate exclusion criteria, we tested about 5,000 blood samples to get our reference interval for all these 4 parameters. So we knew what the normal looked like. Then further, we picked up patients of pyrexia who had registered to us for both CBC as well as blood culture, and only those patients were selected which met at least 2 lab criteria of the surviving sepsis guidelines. And after this selection, we did a procalcitonin level for each one of these patients using the Mindray-Clay analyzer. All the patients whose blood culture were negative were excluded from the study, and at this stage, at this stage, what we did was we calculated the Uden index to maximize the specificity and sensitivity of each of the variables, and we used blinded samples to evaluate both diagnostic sensitivity and specificity. So these are the results. Okay. So as you can see, in the normal population, the mean for Nut-Y was 460, and in bacteremia group it was 490. Mono X we are not taking into consideration because there was not much difference. For mono Z, the mean in the normal group was 1411 and 1537 in the bacteremia group. But if you look at the standard deviation, there is a marked difference. Here it was 39 for Nut-Y in normal and 62 in bacteremia. But when you look at the standard deviation for mono Z, it was 49 in the normal group and it was 314. So in the bacteremia group, mono Z was playing all over the place. It is very evident that mono Z in this condition would not be very useful parameter. So then we calculated the diagnostic sensitivity and specificity, and 2 parameters gave us particularly encouraging results. One was Nut-Y and the second was the neutrophil lymphocyte ratio. So if you look at the Nut-Y, the sensitivity is 1 or 100% and the specificity is 0.933. The positive predictive value is 0.90 and the negative predictive value is 1. So it showed a high degree of accuracy, 0.96, but was primarily a better sensitive marker than a specific marker. But when you look at NLR, the sensitivity is less, 0.86, but the specificity is 1. Similarly, the positive predictive value is 1, the negative predictive value is 0.83, and the overall accuracy is 0.92. So Nut-Y was a more sensitive marker to differentiate bacteremia from septicemia compared to NLR, whereas NLR was a more specific marker. Now when we look at immature granulocytes, you can see that the sensitivity and specificity is okay, but the area under the curve is only 0.613, which means that the model has poor to fair discrimination. This cutoff was working well to differentiate normal from bacteremia, but was not working so well to differentiate bacteremia from septicemia, which means that we can use IMG to establish that the patient has a bacterial infection. But whether that bacterial infection is turning into early sepsis or not is not able to discriminate that well. Next, we looked at mono-Z, and you can see mono-Z versus PCT. It is playing all over the place, and there is, hardly any correlation happening. And this is, we compared Newt-Y with rising PCT. So you can see that, with rising PCT value, Newt-Y values aren't exactly, rising, and the coefficient factor is only 0.2471. So we could not establish a correlation of any of these parameters with the rising procalcitonin values, which meant that each one of these parameters, they may or may not be able to detect early sepsis, but were definitely not an aid to do repeat testing to look at progression of sepsis or recovery of sepsis using particular antibiotics. So our study showed up interesting results to differentiate bacteremia from early sepsis, although we could not find a direct correlation between rising PCT values and any of these 4 parameters. So 2 parameters particularly showed encouraging result. One was Newt-Y, which was dependent on the total number of fluorescence or the RNA DNA content in the neutrophil, and the other was the NLR or the neutrophil lymphocyte ratio. Both of these showed strong utility in predicting developing sepsis. So Newt-Y and NLR are promising markers to differentiate bacterial infection from early sepsis with reasonably high degree of accuracy. These markers can become a robust screening tool to diagnose early sepsis. So the moment you see a CBC which has a Newt-Y above a certain cutoff or an NLR above 10 point whatever was our this thing cutoff, you know that this patient is most likely going into an early sepsis, and you can raise the alarm to the clinician early enough to at least do a procalcitonin value ASAP on these patients and monitor these patients, because these are likely to go from a bacterial infection to early sepsis. However, none of these parameters are reliable to predict severity of sepsis compared to procalcitonin. With these words, I'd like to thank you all for your patient listening. And if there are any questions, I'll be glad to answer.